Hello, everyone. Thanks very much for the time you're spending attending our virtual event. And it gives us the opportunity to explain how our artificial intelligence can help identify as yet undiagnosed sufferers from long-term conditions. Addressing you today from I5 are Professor Dr. Harold Braun. Harold is the CIO at I5 and is also Professor of Health Economics and Artificial Intelligence at the University of Chester. After a period of several years in the city creating algorithms for the insurance industry, Harold has spent the last 15 years providing data analytics and advanced AI to the NHS. I'm Keith Davis. I'm the Managing Director at I5. I'm formerly the head of Europe-wide insurance and reinsurance organizations, and have also spent 15 years in healthcare as, first of all, National Director at the Department of Health, and more recently, I'm been appointed to the board of NHS England's Healthcare UK. Our reputation, let me say a couple of words about it. We've been formally placed amongst the top 100 healthcare digital companies in the country by the Department for International Trade and major NHS entities, obviously headed by NHS England itself, but also several CSUs, more particularly Ardent Gem CSU, NEL CSU, as well as actually directly or indirectly working for the STPs and CCGs throughout London. We have partnerships outside with entities like Cerner, Humana, and IBM, and we're developing more partnerships abroad. What do? We combine healthcare and other data with AI to provide preliminary diagnosis, outcome prediction, service recommendations, and health economy planning. This event today is our opportunity to describe a tool that is used for all those areas I've mentioned. But in doing so, we cannot ignore the fact that we're into lockdown right again and deep into COVID country with no clear path through to the end. We at I5 have some claim to COVID expertise. We were the very first to produce, early in the pandemic, an artificial intelligence-based risk assessment tool. If you're a Londoner, you might well be unknowingly amongst the 4.1 million residents who've already been categorized by the NHS using our algorithms to identify those most in need of shielding. So what is the challenge we're highlighting today? It's because of an estimated 15.4 million patients with long-term conditions, amongst which there are 1.4 million people undiagnosed. Added to these are many more at high risk of developing long-term conditions within the next 12 to 24 months. If diagnosed in time, those lives could be saved, suffering diminished, and the burden on healthcare resources could be reduced. The challenge is accentuated during COVID in at least two ways. Firstly, there are a significant number of admitted COVID patients below the age of 70 years old dying, having no pre-existing conditions noted on their record. Up to the end of June, these amounted to 5,200 in that younger group with, quotes, no pre-existing conditions, leaving open the possibility that undiagnosed conditions contributed to the fatal outcomes. Getting to those earlier could have meant those conditions could perhaps be treated and outcomes improved, thus not leaving it to COVID Secondly, COVID is causing bottlenecks and blockages for those fully diagnosed with long-term conditions. The cancellations and postponements in secondary care are lengthening our already long waiting lists and putting increasing pressure on those patients and the emergency care system. That in itself hides the looming problem presented by those as yet undiagnosed patients building up in the background. Our answer to these undiagnosed patient issues is I5 diagnosis stratification. It is primarily used for case finding through analysing longitudinal health records to identify individuals not yet diagnosed with a long-term condition as having that long-term condition now or in the near future. We see I5 diagnosis stratification as being of even greater importance now we are deep within the dark world of COVID. Now, I5 diagnosis stratification predicts the presence of or onset of 16 long-term conditions. These range from atrial fibrillation through COPD, secondary cancers, right through to CKD. I5 diagnosis stratification essentially calculates the probability of the patient having a long-term condition by finding that patient's digital twin or twins with similar histories amongst millions of other patients who already have the diagnosis. In consequence, those patients can be invited in for screening in the context of NHS health check. Their care can be planned more efficiently by hospital management. Complications can be managed better, and fulfilling one of the purposes of the NHS prevention programme, long-term conditions can be delayed and may be overcome. There are three main use areas for I5 diagnosis stratification. The first is that of population health management. I5 diagnosis stratification enables targeted as opposed to opportunistic screening, bringing about focused early treatment and reduction in NHS costs. Then there's the category of clinicians and management in hospitals. Diagnosis stratification can form part of the hospital's CDS, clinical decision system, as well as contributing to hospital management support by predicting the use of levels of hospital resources. And the final grouping is clinicians investigating the symptoms of the patient can take into consideration future health developments of a specific population or cohort the patient belongs to make more informed triaging of patients and ensuring prioritization. In the same time available, there are just a couple of case studies we could bring to your attention. One from home and one from abroad. Haringey in north central London. The starting position there was that within a population of over 300,000, there was a prevalence of atrial fibrillation of 0.9%. That was well below the national prevalence for atrial fibrillation of 1.9%, and even below the peer CCGs of about 1.5%. And that fact worried Haringey CCG. Something was not right. I will ask my colleague to comment on the figures.
Hello, I'm Harold. Out of 306,000 patients registered in Haringey, we identified approximately 40,000 patients which were at high risk of undiagnosed atrial fibrillation. Of these 40,000 patients, we identified approximately 2,000, so 1,900 that were invited for screening. Now the trick is, by using our tool to identify patients at high risk of atrial fibrillation, we have a very high diagnosis rate, because if you compare to opportunistic screening, these patients have been chosen based on their medical history. So we identified 649 patients, which were 28% of the invited population, as having a positive diagnosis of atrial fibrillation. Now, of these 649 patients which had a diagnosis of atrial fibrillation, approximately 90 would have developed a stroke. Now, the cost for stroke in the first year is around £45,000. The cost of every subsequent year is around £25,000. So saving 90 strokes at £45,000 in the first year and £25,000 in the subsequent year, over 5 years, we're saving £13 million only on stroke prevention. Now, we run the same program in the Middle East, in Saudi Arabia. We were electronically screening 72,000 patients using our tool. We identified 10,000 patients being of high risk of atrial fibrillation. So we invited approximately 900 patients for screening, of which only 59 had atrial fibrillation, which is 7%. So the positive diagnosis rate in a country like Saudi Arabia, for which no data was available to us for the training of the neural network, of the AI, we have still achieved a 7% positive diagnosis rate compared to optimistic screening, where you would achieve normally, ordinarily, the prevalence of maybe about 1.5%. So that is still 5 times or 500% times higher compared to opportunistic screening.
Thank you very much, Harold. Let me move on to delivery and implementation. At the heart of diagnosis stratification is an API we make available, right? The API accepts pseudonymized patient medical history coded in ICD-10. The inference engine analyzes that data to provide a probability indicator of the patient having the undiagnosed condition or may develop it, as I said before, within the next 12, 14, 24 months. A typical in-depth input format involves literally just, an identifier, a pseudonymized identifier, the sex and age of a person, and the hospital, and then receives only a list of patient medical diagnoses coded in ICD-10. And the output, the probability of the individuals, remaining unidentified, of course, to us, of having a long-term condition under investigation. The re-identification, of course, from the pseudonymized list is left to NHS Digital, and they provide the outcomes to the authorized clinicians, principally GPs. Now you can draw from these examples some of the benefits of diagnosis stratification. There's the BAU, the benefits as usual, such as cost-effective targeted screening, efficient care planning, understanding of possible complications, and a very economic way of finding out about these economically stressed, undiagnosed patients. And in the context of COVID, specifically, it can help save lives of some COVID-19 patients with undiagnosed long-term conditions. And of course, help prioritizing waiting lists where undiagnosed conditions are suspected. By the way, we also support our AI inventions with academic papers, and we can make available to you some of these, including atrial fibrillation and heart failure. To have access to our services, we'll provide on the screen the contacts where you can use our system 100 times a month per condition for patients.